Welcome to our Introduction to Pharmacology, where we'll explore the evolving role of nurse practitioners in healthcare. Today's healthcare landscape has seen significant changes in how NPs operate across different states. As of 2015, according to the American Association of Nurse Practitioners, 21 states and the District of Columbia grant full practice authority to NPs, allowing them to practice autonomously, seeing patients, diagnosing conditions, and prescribing medications independently. 17 states maintain reduced practice requirements like Connecticut, where NPs must work under physician oversight for their first 3 years. 12 states still enforce restricted practice, requiring direct physician supervision. When it comes to prescribing capabilities, NPs are responsible for over 8.5 million weekly prescriptions, primarily in categories including antibiotics, antihypertensives, cholesterol-lowering medications, oral diabetes therapies, and non-injectable narcotic analgesics. Understanding the legal and ethical framework for prescribing medications is crucial for every healthcare provider. At the federal level, authorities determine what constitutes a prescription drug versus over-the-counter medications, while states maintain control over who can prescribe and their level of independence. The FDA plays a vital role in drug regulation, overseeing the approval process for new drugs, official labeling, adverse event surveillance, and manufacturing standards. The new drug approval process is rigorous and time-intensive, beginning with preclinical research and progressing through 3 main phases. Phase 1 involves 80 healthy volunteers over approximately 1 year to establish safety. Phase 2 expands to 300 volunteers over 2 years to determine effectiveness, while Phase 3 involves 1,000 to 3,000 patients over 3 years to thoroughly evaluate both effectiveness and adverse reactions. Let's examine the essential components of prescriptions and their requirements. A prescription is fundamentally a permission to take a drug, and it can be issued in various formats: electronic, handwritten, or fax. Authorized prescribers include physicians, physician assistants, nurse practitioners, veterinarians, pharmacists with PharmD degrees, and psychology doctors with PsyD credentials. Every prescription must contain specific elements: the date, patient information, drug name, strength, quantity, detailed directions, practitioner information, including DEA number when applicable, and refill instructions. It's important to note that off-label prescribing, while not indicated on the FDA label, is legal when based on rational scientific principles, expert medical opinion, and controlled clinical trials. For controlled substances, additional documentation requirements exist, including electronic records in pharmacies to prevent narcotic abuse. The Controlled Substances Schedule is a critical framework that categorizes drugs based on their potential for abuse and medical use. Schedule I substances, like heroin and LSD, have no accepted medical use and are restricted to research facilities. Schedule II medications, including powerful narcotics like morphine and stimulants like methylphenidate, require written prescriptions with no refills and expire within 72 hours if unfilled. Schedule III medications allow telephone prescriptions but must be rewritten after 6 months or 5 refills. Schedule IV substances have less potential for addiction and include medications like benzodiazepines, while Schedule V contains the lowest risk substances, some of which may be available without a prescription unless state regulations dictate otherwise. When prescribing controlled substances, specific safety precautions must be followed to prevent misuse and fraud. Prescription pads must be stored in locked areas and printed on tamper-proof paper. Each prescription must clearly display the prescriber's name, NPI number, address, telephone number, and DEA number for controlled substances. Quantities should be spelled out to prevent alteration, and while most prescriptions can be transmitted electronically or via fax, Schedule I-2 medications have additional restrictions. These security measures are essential safeguards in our healthcare system, protecting both practitioners and patients while ensuring appropriate medication access. Healthcare providers face various challenges when prescribing medications, including pressure to prescribe and dealing with patients who misuse medications. The process of rational drug prescribing follows a systematic approach. First, defining the patient's problem, then specifying therapeutic objectives in collaboration with the patient, choosing appropriate treatment, providing patient education, and monitoring effectiveness. To assist in making informed prescribing decisions, we use the ICAN prescribing mnemonic: indication, contraindications, precautions, cost, compliance, efficacy, adverse effects, and dose, duration, direction. This structured approach helps ensure safe and effective prescribing while maintaining professional boundaries and addressing potential medication misuse. In pharmacotherapeutics, several key principles guide effective prescribing. Clinical judgment must always consider the risk-benefit ratio, cost factors, and individual patient characteristics, including beliefs, age, current medications, and prior adverse reactions. Patient education should be provided at a 5th or 6th grade level, covering the medication's purpose, usage instructions, and potential adverse reactions. Monitoring can be either passive, where patients report outcomes, or active, involving follow-up tests. Good prescribing rules include trying non-pharmacological approaches first, using single drugs when possible, starting with low doses, and simplifying regimens whenever feasible. Treatment outcomes are significantly influenced by patient adherence to prescribed medications. Statistics show that only 50% of patients adhere to their drug regimen at 6 months, dropping to 30–40% at 1 year. Patients with asymptomatic conditions like hypertension, cognitive impairment, psychiatric illness, or complex medication regimens face the highest risk of non-adherence. Cultural and ethnic influences also play a crucial role in pharmacotherapeutics, as studied in ethnopharmacology. The Leininger model helps assess patients within their environmental context, considering religious, social, cultural, political, economic, educational, and technological factors. The national standards of culturally and linguistically appropriate services emphasize the importance of interpreters and culturally appropriate teaching materials. Understanding how nutrition and genetics influence drug therapy is essential for effective prescribing. Nutrient-drug interactions can significantly impact medication effectiveness through various mechanisms. Foods can affect drug absorption, metabolism, and excretion through multiple pathways, including passive and facilitated diffusion, active transport, and endocytosis. These interactions can either enhance or diminish drug effectiveness, making it crucial to consider timing of medications with meals and specific dietary restrictions. Genetic variations also play a vital role in how patients respond to medications, leading to the need for genetic testing in some cases to ensure optimal treatment outcomes. The relationship between food and drug absorption is complex and multifaceted. When food is present in the gastrointestinal tract, it can affect drug absorption by altering the absorptive surface area and bioavailability. Gastric emptying time, metabolism, and concentration gradients all play crucial roles. Some medications bind with specific foods, like tetracycline with milk, reducing their effectiveness. Diet composition also affects drug metabolism. For instance, low-carbohydrate, high-protein diets may increase drug metabolizing enzymes. The well-known grapefruit juice interaction with CYP3A4 enzymes can significantly increase drug levels in the blood, potentially leading to adverse effects with certain medications like calcium channel blockers and statins. The influence of diet on drug excretion is particularly important to understand. Certain foods can alter urinary pH, affecting drug excretion rates. For example, milk, vegetables, and citrus fruits tend to alkalinize the urine, while high-protein foods like meat and fish create more acidic conditions. Specific drug-food incompatibilities require careful attention, such as warfarin's interaction with vitamin K-containing foods or MAOI antidepressants' dangerous interaction with tyramine-rich foods. Additionally, certain medications can deplete essential nutrients. For instance, antacids can reduce absorption of folic acid, iron, and vitamin B12, while loop diuretics can lower sodium, calcium, and potassium levels. A comprehensive understanding of vitamins and minerals is crucial for medication management. Each vitamin plays specific roles in body function, from vitamin A's importance in vision and immune function to vitamin D's critical role in bone health and calcium absorption. Water soluble vitamins like B complex and vitamin C require regular replenishment, while fat soluble vitamins A, D, E, and K can be stored in body tissues. Essential minerals like calcium and iron interact with various medications, potentially affecting their absorption or effectiveness. Fatty acids, particularly omega 3 and omega 6, must be obtained through diet and can influence drug metabolism and effectiveness.
This is placeholder media that you'll see if you add a layout to an empty scene. You can go ahead and delete it.